I'm going to bring up here the moderator for this last panel, and I'm going to let her introduce the panelists to you. You probably already know her. We've been seeing her through the whole conference. Dr. Julie Gunther, come on up.
Hi, everybody. I'm Dr. Julie. I'm a recovering system doctor. First of all, let's all give Lee Gross and Hal Schertz and the Doctors for Patient Care Foundation an applause. Yeah. The content and the energy and the opportunity for so many inspired doctors to share their stories, I think we're saving lives, and that may be very self-appreciative or collaboratively appreciative, but this is amazing work, so I'm grateful to be a part of it. I do know who all these amazing physicians are, and in lieu of me talking for them, we're going to do a moderated panel. I think we have an hour and a half, is that right? Okay. The first half hour or so is going to be controlled questions, and we will try to save time for people to just hit this highly educated, amazing panel with everything you've got. They are actually, well, almost everything. I don't know who's laughing, but I have some ideas. So this panel is actually sitting, as best to my knowledge, in order of when they opened. So level of experience, so we're going to hear some different perspectives. But we'll start with Dr. Kissy. If you will introduce yourself, please say your name, your location. I'm trying to see if they can follow directions. Name, location, opening date, rough number of patients, and income now as a proportion of your prior income, if you're willing to share that.
My name is Kissy Blackwell. I own Clarity Direct Care in Wichita Falls, Texas. We have been open for 3.5 months, and currently we have 420 patients. Thank you. I am drinking from a fire hose right now, but it's okay. What was the last thing?
Do you have an income?
I am actually paying myself now, which is amazing. I never imagined that would happen. I didn't plan for that at all, which is great. Percentage-wise, I'm probably making about 60% of what I made in the system right now, so it's pretty good, actually.
Yeah, that's amazing. Dr. Rob? You're good,
I think
yeah.
she's just doing.
Oh, you're just going to do...
That's question number 2.
Oh, that's question number 2. Okay. Yeah. Hi, I'm Dr. Rob Rossborough from Township Health DPC. I'm in Silverton, Oregon. I started in April of 2017, and we currently have 630 patients.
And income as percent of prior?
Income, it's about, it's hard to say because it's your own business. You have some of the, some things that are going through the business, but probably about 60 to 70% of my previous income.
Yeah.
I'm Nick Thompson. I'm from Wichita, Kansas. I own, with my partner, Annie Ahmed. We opened in July of 2016, so we've been open about 15 months. We, as a practice, have about 630 patients, and I have about 500 of those in my name. I will earn in this next year approximately 80% of what I would have made working for the FQHC that I was planning to work for.
Thank you. My name is Thomas White. I am from a small community in North Carolina called Cherryville. It's about an hour west of Charlotte. It's my hometown. Practiced there for 30 years, and then took a year. Some people call it a sabbatical. Some people call it a non-compete. And reopened my direct primary care practice in March of 2015. I really, believe it or not, when I opened the practice, I was going to be happy breaking even. I was very fortunate in terms of finances, and my children were educated, and I paid for the daughter's wedding, and so I really was going to be really happy if I could just practice medicine and do what I always had wanted to do. It turned out I actually had an income pretty quickly. I'll talk about this probably in a few minutes. Just added a new partner right out of residency, and he's actually in a second location. And so right now, my income is on hold, my salary is on hold as I support him as he gets started with me as a partner.
I'm Jen Heriter. I'm from Topeka, Kansas, and my clinic is Oasis Family Medicine. I'm a co-owner with a nurse practitioner, which is a little unique situation, so if anybody has questions about that, I'd love to talk to you about it. We opened in March of 2015, and I started first. She came along 6 months later, and we now have a third provider. So we have 1,410 patients in our practice. 600 and some of those are mine. And the way I kind of think about my salaries, I'm making what my base salary, right? You know, you do the fake math of how you get paid in the system. So I'm making back what was my base salary, but it's pre-tax and no bonuses. So it's probably about 80%.
James Pinkney. I am the CEO and founder of Diamond Physicians in Dallas, Texas. Started the company in 2012. We opened our doors in May of 2013 with 2 physicians and 0 patients. We now have 4 locations, 7 doctors, and just under 2,000 patients in 4 years. Started the practice right out of residency, so I was making 0, and now I'll just tell you I'm blessed and highly favored.
I'm Jessica Davis. I am in upstate New York, a little bit north of Albany. I saw my first patients in February of 2009, finished residency, started straight out of residency, finished off cycle in October of 2008. So I've been open almost 9 years. I have about 220 right now, and my full to stay part-time is only around 250. And I've made, as we talk about this, I've made lots of choices purposefully to do that. So my income now is, having started straight out of residency, I'm making about what I was making in residency.
Thank you. If you guys want Jen, will you turn off the microphone, and James, will you turn off the microphone and undo them from the thing? Then you guys can pass them and they're not in front of your face for the audience watching on the live stream. Hopefully that's an improvement. You just pull it out forward. There you go. Okay. One thing I should say, because I don't know if it's come up at this conference, there are some restrictions, particularly related to CME and just general good business behavior around explicit discussion of what we all charge. So that will come up today. We're not trying to be vague, but we have to talk around our per member per month fees. Everybody here has a website. Pretty much everybody here has their prices on their website, and you have everybody here's names. And then you can certainly meet up with people after this if they're not flying away and hit them up for specific prices. So I just bring that up right now because sometimes that comes up in conferences. Why are we so vague about what we charge? I'm actually going to ask that just as general guidelines. So with this panel, there are a variety of models, a variety of charges. Does anyone at this table charge less than $500 a year on average? Okay. Does anyone at this table charge more than $2,000 a year on average? Okay. So as we talk about our personal business models, you'll get that there's the parameters, okay? So question number 2. Actually, I'm going to switch questions 2 and 3. Sorry, guys, because I think question number 3 is more exciting. If one thing happened tomorrow that would definitively kill your practice, done, gone, over, destroyed, what would make you fail tomorrow? And you can punt, you can phone a friend if you have to think about it more.
Well, I think it might actually be something that's kind of close to your heart a little bit. I did get some disability insurance from the AAFP, and it's not great. It's not good. So I think if I were to get sick and not be able to run my practice, I think I'd probably be in trouble at this point. So that'd probably be the one thing that would kill my practice right now.
Okay, so tomorrow Kissy's going to get disability insurance. If my Northwestern Mutual agent is watching, you can call her. Okay, no, that's excellent. That's excellent discussion.
So, being in Oregon, I'm the lone red state over in the corner, and all those bad states that. Anyway, so I think if the insurance commissioner decided that all of a sudden DPC was not a fit or wanted to shut us down, I think that would probably be the biggest thing for us.
Yeah. So I think if something personally happened to me, that would be the definitive blow to our practice. But taking on another physician or having a partnership, having co-ownership of a business, and just sitting and thinking about that, what happens to if my partner gets sick or dies? Do I have disability insurance cross-covered onto him so that if I have to pay the value of our business to his wife, that's more than what I have cash to be able to pay. And so that, I think, is something that we don't think about a whole lot, but my partner's value in the business, if he is to step out or leave, is something that really could be difficult.
Thank you. So this sounds like there's going to be a common theme of sort of possible pessimism here about health. And for any of you in the room who are also 64 years old or older, you know that we're vulnerable. We're all vulnerable. And so my practice is in my hometown. It took me 6 months to realize what the name of the practice should be, but it's Hometown Direct Care. And what worried me, and still does to an extent, if something were to happen to me, it being a small independent practice, what would happen? I wouldn't want the hospital system that I left to somehow acquire it. I'd want it to continue. And I hope that I have solved that one worry by bringing on this new young physician who is incredible. And he would be here today, but today's his daughter's first birthday party. But he would be here with me. So I really feel like I solved one of my biggest worries that would, quote, kill the practice. When you're solo and you're alone and you have white hair, you think about those things.
At the risk of sounding like a parrot, if it was myself or my partner that had a significant health issue or a death, certainly that would put our business at risk. I hope in the way that we've set it up, it wouldn't kill it entirely because we are several providers deep, but it would definitely be a major hit. And then, of course, if legislatively something happened where we had to drive our efforts more underground, then I think we certainly would have, a big hit in that way as well. If we couldn't preach the word of DPC as loudly as we can, then that would kill it.
So to try and change gears a little bit, because those are all great sentiments, I think growing too fast would be devastating to my business at this point. We're going to open our first location outside the DFW Metroplex in Atlanta next year, and it's scary, but it's also exciting. So having the infrastructure in place to grow, but not grow too quickly, is very important.
I won't echo all the personal reasons, disability, things like that, being a solo practice. Being in the state of New York, they throw around single-payer legislation. There's a lot of HMOs. Something like that could happen. But when I started my practice, I would say that I built it this way to ride out all the political turmoil, ride out whatever's happening with insurance. By just doing my thing, doing DPC, I think you can ride out. It would take like a direct law saying you couldn't privately contract with patients or something to kill it, I think, because my patients would find me, and if worse comes to worse in New York, I'm not that far from Vermont, I'll just move and get a different license.
Thank you, everybody. So Lee asked that we specifically comment on failure. And I made the executive decision without talking to Lee that I think these fine people have way more amazing pearls to share than commenting on the failure of some practices. So I'm going to give what I believe is one huge failure pearl, and it's a little hurtful, but hopefully it's helpful. I would say that the majority of DPC physicians I spend time with, even if I don't philosophically agree with them, are dynamic and highly likable people. So my recommendation to physicians debating whether or not this will work for them is to decide if you're likable. And how do you figure out if you're likable? Because people generally are kind enough to not tell you you're a real jerk to your face. So other than spying on other people's Facebook feeds about yourself, my thought is this: if whatever your practice model is, if you've never heard a patient say, "Oh my God, thank you. Will you see my mother? Will you see my wife and she said you were fantastic, so I had to come meet you. Will you take care of my daughter?" If you don't hear these things in your practice, and it doesn't have to be every day, but if your experience in your routine practice is not getting direct feedback from your patients that they want you to care for other people in their lives, then the reason you're busy is because you're the one who has openings. So if you're highly unlikable, you're going to have a hard time compelling people to pay you to be their doctor. And maybe that's a hard truth, but go find your best friend that you drank with in college and ask if you're a hateful person, and she or he should tell you that. So, because that's what best friends do, right? Okay, so with that said, what I would encourage the audience to do is with the next question, as these people answer it, as these physicians answer it, reflect on what the counterpoint might be, because that might be another thing that would lead a different practice to fail. So what is your biggest challenge right now?
Well, it's kind of funny because it's actually something James said earlier, which is that I have grown really, really quickly. So being open only 3.5 months and having 420 patients, I really do feel like I'm drowning sometimes. So I feel like I've gotten it a little bit better under control. I am still seeing probably about 11 to 13 patients a day. So it's more than I anticipated, and I do try to fit my texts and my emails and all those things into kind of like visits through my day, so that probably I'm seeing about as many patients in that regard as I was in the system. So that's been my biggest challenge, and I'm hoping that it's either going to taper off a little bit or that I'm going to have to do something to slow just a little bit so that I can breathe.
So, Dr. Kissy, what is one or two things you think you did that led to this incredible straight out of the gates growth?
Well, and that kind of brings me to my pearl too, because I think the biggest thing that I did, and of course I had a lot of advantages. My hospital was very, we didn't have any non-compete, we didn't have a non-solicitation, and so I could solicit each patient at every visit in the 4 months notice that I had to give. And I took every patient encounter after that as a marketing opportunity. And even if I only took 1 minute to say something about it, of course they always wanted to know where I was going and could they come with me and all of that. And so I did. I marketed to every single patient, and I think that made a huge difference.
Did you take pre-enrollments before you opened?
Yes, I did. I took pre-enrollments. In fact, as soon as I told the hospital I was leaving, I opened up my website was open, and patients started being able to go there and all of that. But my pearl was really that if you're, especially if you're employed or if you have patients now, is to really start being a DPC doctor now. Give patients, if you have an Atlas number, if you have a Spruce number already, go ahead and give them your Atlas number when they need something. Say, hey, you know what, so that doesn't happen again, here's my cell phone number. Most of the time they never contacted me, so it wasn't that big of a deal. But call them personally, spend an extra 2 minutes, do something to kind of show them that when you leave, they want to go with you. And I think that made a big difference too.
So I'm going to moderate my moderator power. So Dr. Jen, my recollection is you had a similar startup to Kissy. Will you comment on your biggest challenge now, but then some success, what you think you did successfully in the beginning?
I was very fortunate that when I left my employed practice, I did have a non-solicitation clause and a non-compete, and I approached our CEO and said, hey, here's what I'm going to do. And once he was sure I wasn't going to work for the competition, he asked what he could do to help, and I asked him to waive it, and he did. So also, as soon as I gave notice, I was able to start soliciting the patients that I wanted to come with me. And, we got our website up and going, we got our Facebook page up and going, and we're able to really get started spreading the word. And so we opened our doors after about 3 months of pre-enrollment with about 250 patients. And I allowed myself to get paid at $400, and that was 3 months in. And so, I do think it makes a difference. I think the lesson that comes out of that is, all these scary things like non-competes get thrown around, and sometimes they're held up and there's no way around them, and it's good time sometimes to really figure out what you want to do, and sometimes they're not. And when you're blazing a new trail, sometimes nobody's asked, hey, how about if you just let me out of this? And they say, oh, okay, I guess we can do that. So I think it's always worth asking, but and then our growth has just continued from there.
So Dr. Pinkney, your growth has been pretty remarkable to have 2,000 patients, and you were straight out of residency. So will you comment on your sort of startup story and then your biggest challenge now?
So I think the biggest challenge when it comes to starting up was acquiring funding. So it was back in 2011 when I first started shopping this model to different banks, and the market was still tight, 2009 financial crisis. So I had a wonderful business plan, and 9 different banks basically said no. They loved the idea of DPC, but I would have been better off just presenting a normal family medicine business plan rather than a DPC model. And I had to work in the ER for a couple of years, and I made quite a bit of money that then went to my startup capital and allowed me to attain a loan.
Thank you. What's your biggest challenge now? And you kind of mentioned it, the growth, but is there another one you've?
So currently, I think trying to break into the municipality and large employer market has been really, really tough. We have several small businesses, 5 to 25 lives, and even a few mid-sized businesses at 50 to 100 lives. But when we're trying to attract municipalities and cities, as well as 1,000, 2,000 life groups, this model is just so efficient and provides so many cost savings that Dr. Savage reviewed yesterday with the imaging and lab discounts. And when you take primary care out of the insurance equation, we can really save companies 30% or even more off their bottom line. So when I analyze claims data for 5 years and go in with a proposal that saves a company $7 million, and the cost of our services are far less than that, it's kind of a no-brainer decision, but they're still like, oh, we'll think about it. It's frustrating.
Yeah. Jessica, you started straight out of residency, so, and I realized I just did a super gender snafu, which is calling women by their name and men by doctor. So Dr. Jessica, thank you, Dr. James. Dr. Jessica, will you comment on your biggest challenge now and sort of help everyone understand how you started up?
My biggest challenge now is nothing terribly exciting. I'm at the point where I'm sort of cruising, just working on optimizing flow, technology, making sure I'm happy, my patients are happy, and suddenly I've been slowly growing for 9 years, and I never really thought about what next when I'm full, and that's suddenly coming up in the next months to year. So I'm in the phase, many of you, am I gonna add another partner, a nurse practitioner, or do I just stop and say I'm good for a while? So I'm figuring that out. Nothing earth-shattering in terms of challenges. My challenges were all 9 years ago, doing everything the hard way. Started straight out of residency. I started before DPC was really a thing. The term existed, I think, but it wasn't where we are now. I did my residency in one part of New York and then moved back to my hometown where I didn't know anybody, had no medical connections, had no real community connections. Opened in I guess the point of all this will be to say the challenges, I did everything potentially wrong, or how people will tell you not to do it, but I'm still here 9 years later, and I'm really happy. So I'm not monetarily rich, but I'm life rich, and that's what my goal was. So challenges specifically to run through a lot of the things that are hard or doing things the wrong way, in quotes, but I opened in a super small town where I didn't know anybody. I'm in New York, which has no med dispensing, no lab client billing, so I don't have any of that fancy cost savings that many of you can do. I didn't choose to do any moonlighting. I wanted to have more kids, so I took long maternity leaves and focused on family for a while. I homeschooled my kids for a while, and those were my choices. But through all that, I have steadily grown. The word of mouth is definitely out there. I have a wait list now, so things are kind of on cruise control.
And then Dr. Nick, so you started out with the business model with a partner, but then you opened for a year without a functional physician partner because he was finishing up residency. So tie it all together.
Yeah, so, it's that my biggest challenge was 3 months ago, was when we had grown by 50 people every month for like 12 or 13 months, and I was drowning, and my wife was drowning, and I was seeing 14, 15 people a day, and didn't want to slow that because I knew that this partner was going to be beginning to see patients. And interestingly, so I hit in the low 500s, stopped taking new patients, and I regained my joy. I got back to the spot that just felt right and was where I was able to deliver great care, keep relationships. My family is much more healthy now, but riding that startup wave is hard. You start out and you don't have enough people, and then all of a sudden you look and your business isn't running efficiently, and then you have too many people and you can't even think about the business. So adding a partner has been, or starting with a partner who then ended up coming on as a physician later, was a great kind of relief valve for me. And I am so happy that we started the practice together rather than trying to add someone in later on, because we were able to share a lot of the administrative burdens. It was way easier to structure the business financially when we both put in the same things and did the same stuff from the beginning, rather than to try to value the practice and then have somebody buy in when who knows how much work I've put into this over the last year. And so I think that was a good move for us on that end.
Dr. Tom, your biggest challenge right now, or just kind of where things are for you?
So, biggest challenge. When I opened my practice, my goal, believe it or not, was 300 patients, because I thought that would feel to be about the right amount. And then when I went past 400, I went like, whoa, what happened? What I realized was that because I'd been in the community 30 years, many of my patients would be patients I'd been treating for 20, 25, 30 years. They would be older. They would have more needs, more problems. And I'd say that's probably my biggest challenge now, is that my 400 patients, many of them are 1.25s, 1.5s, 1.75s. And so I think it's, maybe for what it's worth, coming from me, that's really important to keep in mind when people are comparing how many patients they have in their practice, because it's age really matters, the complexity of the patients really matters. And so 600 patients here and 500 patients there may be two very, very different things. So I keep that in mind. Josh Umber reminds us frequently, pricing is really important. So you have to know your community. If you price too low, you have to have way too many patients, right, to make it work financially. If you price it too high, fewer will join. you price it high, you may get simply a little more well-to-do older folks. So you got to take all that into account. So I guess I would, trying to say, compare numbers of patients and practices with that in mind. So the challenge right now is that what I did in my community actually seemed pretty easy. People knew me. I had invested a lot of years in that community, growing up there and then practicing for 30 years. So it seemed pretty easy for me to get to where I wanted to be. My new partner is not known in the community, and so he is selling himself, of course, but also just the model, the business, more than I had to. So it's going to be really interesting to see how it grows for him. He's in a second location. He spends time in my office, but it's really going to be an interesting process to see how he grows, because really, other than a few family members nearby, he's an unknown quantity. So I think the challenge we have is just seeing how that works and how do we market that because it was a lot easier for me.
And Dr. Rob, my dear Northwestern friend, this guy's a fisherman and would probably rather be fishing, although, anyway. Tell us your latest, greatest challenge and sort of how things have met your expectations for a startup.
Well, I was in, sort of like Tom, I was in practice for 20 years in a small town in rural Oregon that happens to be a really family practice-centered town, which made a big difference. So there's 20-some family doctors from multiple independent groups and then a hospital-employed group. And I was a part of a big 10-physician group, and just like all of you while you're here, got so disgusted with the way I was taking care of patients because of the time constraints and all of the insurance requirements and everything. And I finally just had to do it for me and for my patients. And so making the leap was actually the biggest challenge for me at the time, because I was just afraid. I mean, you're all here. I mean, the fear is the big thing that holds us back. And so I, decided, opened the doors, and it's been snowballing ever since. I think, I started in April. I had about 3 months ahead of time where I could, talk with everybody in the community that I could talk to. I talked with all the patients that were coming in the office, and just spent lots and lots of time just selling my vision and why this is going to work better for people. And so that was the key thing for me. I opened with about 200 patients pre-enrolled, and once the doors open, it's just been gangbusters. So, and so my biggest challenge is managing the growth. I think the biggest thing that helped me the most was that when I left my old practice, I took our office manager. It literally was Jerry Maguire with the fish, and I'm like, who's with me? And so my office manager, Janet, she joined me and helped me start the practice. So she's got enough business sense and enough, just savvy to help with the background business part of it. So that was so helpful for me. And so we started together and sort of built this vision. And then once we were in a month or so, it got to the point where we felt like the office visits were getting a little clunky because we're seeing patients and we're trying to answer phone calls, the phone's ringing off the hook, and, filling medications, which is totally brand new, and we're like, trying to count as fast as we can. And so we decided that, we're gonna hire my medical assistant of 20 years who's a known commodity in town. We hired her right away when we hit about 300 patients. And we're a team, and that's what really worked well for our community, because they know all of us. So I'm not there today or the last few days, but they're in the office. They're filling meds. They're constantly calling me. So we are able to grow because of them, really. So I think the biggest challenge for me is going to be like, okay, so now there's an opportunity to get a big portion of my building. I can actually buy the rest of the building. Do I add another physician? How do I do that? That's the next phase.
Next step.
Yeah.
Awesome. So 56 minutes left. I would like to open it up for questions. So unless no one has questions, would you mind going to the microphone so the people on the streaming can hear the questions? And then that creates kind of a queue that's fair. So someone asked at a lecture earlier today about practice finance or loans. I don't know if that person's here. I got a loan through Wells Fargo. They actually have a physician practice finance division. I would encourage, just as a small business yourself, that the more businesses you go to in your local community, those 9 businesses that Dr. James went and talked to, while they didn't give him money, they all were educated about DPC. And as Dr. Jen said, is you're planting seeds everywhere you go. The coffee shop, your new lawyer, the accountant. Every small business person you're meeting to help you build your small business, they'll get it. They got it when they do this. They all go, the head tilt. And until you get the head tilt, how many people, I don't know if you see that, they don't get it yet. Direct primary care is so simple that people really have a hard time getting to the head tilt, where they're like, oh. Anyway, so yes.
Cindy Richards from Charlottesville, Virginia. I've given notice to my employee practice, and I'm in the process of hopefully opening in the spring. One of the fears I have, I love my elderly patients, and as I'm talking with them about this, they are extremely suspicious, and when I use the term opt out, they immediately go, I can see it. I'm not good at the marketing end of that. I'm working on it. So one of my thoughts was, in doing my pricing, which I know we can't talk details, was to have a flat fee for everybody, not cheaper for kids, because I really want my elderly folks. I love them to death. I don't know that they would necessarily appreciate that, because they still consider this really suspect and expensive on fixed incomes. They want their Medicare taken, and they're mad that I am not doing that. And I'm just kind of curious your thoughts on that, how you've dealt with that and managed to keep them.
Okay, thank you. And congratulations, by the way, lady. You found out about DPC this year, right? Was it this summer?
2 years ago,
Okay.
a DPC doc near me saw me sobbing in a corner at a conference.
Okay.
And grabbed me.
Good for that person.
It took
whoever
me
they
a
are.
year and a half to have the courage to come to the conference she forced upon me like a couple years ago. I finally came in June. Definitely had to run from the conference middle of it just because I was scared to death and terrified of you guys. And I'm not, I'm not outgoing. I want to just take care of my patients, but I can't do it in this model anymore. And I'm hoping to still stay in medicine.
Yeah. Yeah. Does anybody, Dr. Tom's going to take a hit at this first.
Yes, no, excellent question. Over half of my patients, of course, because of how long I'd been in the community, have Medicare. And I agree, initially there was a great deal of skepticism and concern, and I don't mean this ugly, but many patients of that age begin to see their glass as half empty. And so it was a little challenge in the beginning. I did same pricing except for children. I didn't have tiered pricing. And my initial discussions before I ever opened with potential patients and people I was close enough to talk to, I think the older individuals I talked to were put off by this idea that they were going to be charged more. They sort of realize they require more care, but they don't like the idea of being charged more. In fact, they're used to getting the senior citizen price when they go to, a restaurant. So I kept that in mind. Now, I did something absolutely crazy, and I don't know that anyone in here should do this. I talked to, first of all, your best consultants are like these people and the people you've heard this weekend. But I made an error, and I talked to a consultant who turns out didn't know anything about DPC, but I felt like I had to talk to somebody. They said, oh, for house calls, you have to charge this inordinate amount. You'll be killed if you do house calls for anything less than, it was a big number. And I thought about it, and I thought about it, and said, no, house calls are going to be free, included. And the funny thing is, almost no one ever demands them. It gives me the freedom that if I want to stop at someone's house on my way home from the office or church or wherever, it's not, I don't have to decide, did they ask me to come or did I decide to come? It's a house call, and it's included. And so the more you offer, it's sort of like being on call 24/7. The availability makes people use it less. But for me, building that into the business model, I think folks were so grateful. And so once I'd been open 6 months and I went to see Mrs. So-and-so and Mr. and Mrs. So-and-so, and they knew I would do it. After that, it was the selling of this to folks of that Medicare age was really pretty easy.
And your Medicare patients understand how it used to be. And I guess my personal pearl is you're never going to get in trouble legally, medically, ethically for telling your own personal truth, which is, this is what called me to be a doctor, and I simply cannot do that this way anymore. And for me to continue to take care of people the way I want to, I have to go here. So to not make it about, and patients are extremely confused about their health benefit across the board. I wouldn't talk to patients about opting in or opting out because they just get all tangled, and that's where they think about fraud. And frankly, it's irrelevant to them whether you're opted in or you have to inform them when you do opt out. Medicare has a template letter you have to send them, and they get really confused. And I have one I can give people a copy of, and I'm sure there's one on DPC Frontier. But in terms of talking about your vision, talk about your vision. And just because they can interact with the entire rest of the healthcare system in the same way. So the way you just say it is, instead of an office visit fee, instead of a copay, you pay me to be your old country doctor. And people say, well, I don't want to pay more. And you say, I understand, and I wish I could stay here and do this, but I can't. So I don't know if anyone has more on that or if that's saturated.
Yeah, I tell my people that we're selling relationships. I mean, it's about, I'm going to be your doctor. It's not about insurance anymore. It's like, I want to do the best that I can do to take care of you. And, a lot of my seniors are like, they look at you like you got 3 eyes when you say that you're not going to use insurance and opting out and all that. But they're all starting to come back around. And then the other thing that I did, we decided that when we left our old practice that everybody over 85, I didn't want them to go find a new doctor, and so we just see them all for free. They're all in our practice. They're, in the ALFs, and there's some homebound people and people that it's feel-good stuff, Yeah. I mean, I literally cried the first time I did a home visit for a guy that has Alzheimer's and he's trying to stay at home, and I'm like, this is the first time I feel like a real doctor,
Thank you. Yes, sir.
Yeah, my question actually about the small business and for Dr. Pinky. How do you convince the small business owners to sign with you? Because the question is, this style is not compliant with Obama mandates, like to have insurance. And so how do you convince them to pay extra? Plus, insurance, they have to sign with the insurance. So how do you convince them?
Sure, that's a great question. So for small businesses that don't have any insurance plan, it's actually an easier sell. So they want to add a taxable benefit to their company and their employees. It's actually pretty easy. You present all the positive aspects of DPC, unlimited visits, no copay, 24/7 access to your doctor, unlimited urgent care for one low monthly fee. I've done that a couple times. And when you explain the value, then they may bite. They may sign up for membership. It gets more complex when they actually have an insurance plan, because then they don't want to spend even $50 more on top of what they're already spending for their employees.
And I would discourage anyone, what Dr. James just demonstrated is a result of many years of practice and learning insurance speak. We don't have to solve the whole problem, but I'm wondering if Josh is in the audience. He's probably outside. One thing that some of the practices that have worked with small businesses have done very successfully is they've found an insurance agent that they can sort of have a collaborative relationship with, who helps with the other half of this conversation, who helps with an analysis of the total benefit. The target market are right now, because of Obamacare regulations, are companies with less than 50 employees who are capable of being self-funded. So the conversation you're asking about, this conversation is very difficult for massive, large employers. That's almost, you can still do cash-priced healthcare, on-site clinics, you can do iterations of this, but it's a little bit different than what we're talking about when talking about working with employers.
And then one more pearl, when you are working with employers that have an insurance plan, if you can convince them to go to a self-funded or partially self-funded plan, there's some TPAs out there that are partnering with DPC groups and giving you a 10 or 20% discount on the premium. I did it for our own company, so we are large enough now to go self-funded. And all of our employees go to different doctors at different locations, so we're able to kind of leverage the amount of employees that we have and really take control and seize control of every insurance or every healthcare dollar that we spend. So you can do that for groups as small as 10 people now. But unless you can either have a cost-neutral plan, meaning that you save them the same amount of money that it costs for your service, it's very hard to sell small businesses.
Yeah.
Just to comment first, I'd like to thank Dr. Tom for making the distinction between 500 of this type of patient is different than 700 of another patient. I mean, sitting around, I have a big group of Medicare patients. I would love a big group of children, but where I practice in Maine, most of the families are in an HMO plan, so the kids are in HMO plan, so that just also, the age of your practice differs depending on where you live. My question is about the waiting list, and is that something that you put on your website? Is that something you say when someone calls? And how do you work your waiting list?
Okay, Jessica. Dr. Jessica.
I love my waiting list. Lisa Davidson talked about this too, I think, but I'm not full, but I still have a waiting list. My practice is focused on peds, and you say you want peds in your practice, you can do things to attract them. I just say I'm only taking newborns right now, and they're family members. You can come in if you're coming with a newborn. So I have created more of a niche practice, but it's the vision that I want. So anybody, I do automatic meet and greets for everyone before I take them into the practice. So when somebody sends an interest form through my website, we sort of have the automated process with my assistant. We'll get back to them. Newborns automatically kind of get scheduled for intro visits. Anybody older than that automatically gets put on the wait list. And then when I'm feeling slower, I grab people off the wait list. If I'm feeling busy, I just leave them on the wait list. And so it might be 2 days. My assistant will automatically put them on there, and I'm like, actually, you know, they're a friend of so-and-so. Let's pull them right in. Others might sit there for months, and it gives me a little bit of filter as to who I'm taking in and how fast or slow I grow at this point. But I'm not full. I could choose to just work my butt off for a couple weeks and fill. But one of my pearls is that everyone talks about the startup and the fast growth. I never wanted to do that, and so I didn't. I have never felt like I'm drowning. I've purposefully slowed things down so that I can save my sanity, not burn out doing DPC, so that I can do this for life. But the waiting list has been a really nice part of that, if that answers.
Yeah.
My name is Brad Reedy. I have a traditional practice, and I've just been tossing around this idea for the last, year, and I just want to see if I understand. What I have heard from this weekend has been mostly quality of life has been a big difference, but when I hear with the panel, everybody has said that they were making less than what they were traditionally making in the other option. I'm just wondering if we're selling ourselves short in terms of financially when you take a look at this is really saving patients, everybody, a lot of money. And when you're taking a look at are we selling ourselves short in what we're trying to do through DCP, and I guess my question more would be to Dr. Pinckney, are the physicians that you have employed, are they getting comparable compensation as what they would be in a traditional system? Or is this something that we have to just take a look at as financially we're going to take a hit, but quality of life is going to be significantly better?
That's a good question, and that's an important question. So a lot of you are on your iPhones. Will people do this math for me? 10 times 600 times 12. What is that? 10 times 600 times 12. Someone do that? What? $72,000. So if you're off by $10 a month on your business model, it's a $72,000 difference. Do 15, I think it's 108,000. So are we undervaluing ourselves? That's a very important discussion. I'm going to let loose on the panel, but I asked a number of very successful DPC docs, some of whom are on this panel, some of whom aren't, who've been open for a while, what their income was. And I was actually surprised that about 75%, and it was about 20 docs, 75% were not taking a salary. Some of them are reinvesting in the business. Some of them are looking at adding a partner. But I think it's actually, there's a Pollyanna version and then a pessimism version. The Pollyanna is, what an incredible testament to our profession that we take on entrepreneurship with no intent of greater financial gain. Now, it's probably also problematic, right? We take on risk in entrepreneurship. When I met with my lawyers at startup and explained everything, they said, well, with your vision, you're going to make less. I said, I know. Well, why would you do this? I said, you don't understand what it's like to be a doctor in the system right now. So I said earlier, nothing pays like autonomy, and I think if you're truly called to, I don't like that word, if you had a vision to be a certain type of doctor and then you get to do that, it sounds super Pollyanna-ish, but Dr. Rob cried at a home visit, okay? He probably cried over his last really big fish, but getting to like live your vision is crazy cool. So with that, I'm going to extend to the panel a version of your question, which is, do you believe you undervalued yourself, and would you price yourself differently if you opened today? Quick answer. Yeah.
We undervalued ourselves, and we increased our prices this month by $5 for adults.
Okay.
And so we've made that change and realized that. We also were expecting to have fewer pediatric patients, and we have a third peds. So we are very young family heavy, and that was something we didn't expect. So we, after a year, reevaluate, change the model.
Anyone else?
I think I'm with Nick. It's we grew really fast, but our patient panel, I thought a lot of the old chronically ill patients that were high utilizers in my old fee-for-service practice would follow me, and really they didn't. They're still up at the old practice, and so my practice right now is mostly young families and peds, and so it's much different to take care of 600 people that really don't come in that much, and if they do, it's an earache and it's no big deal. So I'm not sitting long-term with multi-chronic illness patients, so that makes it easier. But yeah, I would definitely increase my rates, $5-10 a month probably.
And the national, I can say this, the national average based on the good work of Dr. Philip Eskew, was that a 3 years ago study? 3 years ago, the average per member per month price of 100 and some DPC practices he studied? So median was 75-80, average was 90 to 95. So there's lots of different ways to figure out your pricing, and I guess we could talk about that too, but yeah. Dr.
Just really quickly, what it looks like I'm taking home is not that much, but if I was working as much as I did in residency, I'd be like a millionaire. I'm working a lot less hours to make a reasonable income, and I'm at the point where our car died, I need to make a car payment, I'm gonna take some more patients this month and I can ramp it up, but I don't do that all the time, but I can, I'm way happier. The freedom is unreplaceable. I would never go back just to make more money. My goal is, a good life, and my practice is part of that life. My goal is not to get rich. My goal is to make a good living, but that's enough.
That's a great question, Dr. Brad. I encourage you to look at the pricing table backwards. Most people think about, okay, how much can my patients possibly afford when they're starting their practice, and look at different models from around the country. But what I want you to do is actually look at how much money do you want to make, how much money do you need to sustain your lifestyle, and then how much money do you want to make moving forward. And when you work backwards, you can actually extrapolate and figure out, okay, I need to charge X, Y, Z. How many patients do you want to see? How busy do you want to be? Everybody has different goals and aspirations, so it's very important to go through this exercise before you lock in your price point. That way you can have a price point that you know will generate the income that you need to live.
Yeah, that's someone asked on one of the forums, what should I charge? That's your business plan. You don't have to write a business plan. People say, oh my gosh, how do you write a business plan? It's so hard. Come on, people. You took the MCAT. You can write a business plan. And some of us took the MCAT more than once. So
I'm going to answer your second question real quick.
Yeah, Dr.
Julie.
Tom.
So your second question, we average a little bit more than the typical DPC practice. It's still less than a cable bill, but our physicians actually make about 40% more than the standard traditional insurance model salary. So, our physicians are very happy, and we have different business models for our physicians to join us. So some physicians are employed. They make a percentage of collections. Some physicians have opened up their own Diamond branch, and other physicians have joined us as a corporate partner.
Dr. Tom?
So a couple of things to keep in mind, I think, about income. And one is that, to our credit, those of us who chose primary care and family medicine, we made a decision about income in medical school. I've always thought that I should make as much, if not more, than some of the knuckleheads who were in my medical school class. And I still believe that very, very strongly. But that's, we chose primary care and family medicine for other reasons. Now, that's not to say we shouldn't enhance our income. I think it's important to realize where this direct primary care movement, if you will, is right now. There are still a lot of solo physicians. There are practices that have only been open a couple of years. Some of the folks on this panel who have partners, and they're maybe beginning to see those economies of scale and shared overhead that many people, like the 20% not taking an income, aren't realizing yet. I also think as we get better at what we're doing, we can have larger and larger panels. Patients right now still, at least in my community, this thing of communicating with me by email or Skype is foreign to them. They think they have to go to the office. As we mature our practices and our patients learn that not everything requires a visit scheduled 3 weeks in advance, I think we can be more efficient. We can actually take care of more people really efficiently, but we're all learning. We're learning, patients are learning. So I think where we are now is not where we're going to be in a year or 2 or 3. So anybody that hears that, well, I can't go without an income, let's look down the road. I think direct primary care is going to be much more attractive from an income standpoint.
Yeah, and you're also, so you're probably taking a salary from your business, but you're also growing a business, and that has a value to it that if you decide to leave your employed position, you leave there with zero besides what you earned as a salary.
Sometimes they give you a watch or a hummingbird light. I did get that.
Yeah.
5-year service award. I'll post a picture online when I get home. It's pretty. Sorry, I'm sarcastic. Yes.
Becky McGilligan, Cincinnati, Ohio. I am one of the lucky people who I put my notice in. It's a 6-month notice, but I don't have a no compete and I don't have a no solicitation. So I took your advice that I saw in the Facebook group, and I have been talking to every patient, or most every patient if I'm not running too behind. One question I have is I have less than a handful of people that I know under no circumstances will be able to afford my fee, but I really want to continue seeing them. And hearing you talk about seeing the people over 85 for free, can I cherry pick? One's a Medicaid patient, and another's a couple like Holocaust survivors, dual eligible, and I really want to continue to see them. How do you do that legally?
Are you going to opt out?
I am, immediately.
You can do whatever you want.
Okay.
But make it explicit. Sorry to cut the panel off. Make it explicit. So here's what you don't want. You want, I'm going to scholarship this group. Well, this is my strong opinion. I'm going to scholarship this group because I've mapped out my business and I can afford it. And everyone else is going to have to pay. And I'm going to get the price where I ethically believe it's appropriate, so I'm not going to discount it or negotiate it. It is what it is to make this work. And I'm going to make this work because that allows me to take care of all of them. And that in-between space of the I can't, I won't, I'm not sure, yeah, I'll be right back, I'm going to go to the ATM. That group, let them go. They will kill your business. But yeah, I take care of 5 people per year for free. And there's a 1-page piece of paper they have to fill out because people won't fill it out. And it also documents that in 365 days that they may no longer have free care.
Do you do like a non-disclosure agreement with that so they don't tell their friends?
Not really. I just tell people, I say this is a special circumstance because I would like to continue to be your doctor. I'm really transparent with my patients about my income, which is very, very low right now for a number of reasons, which I can share. I hired a nurse practitioner and an MA, and they have my salary right now functionally, but that was an explicit decision. But if you opt out of Medicare, build whatever you want.
Okay.
Is that okay, Phil, sort of to say? More or less. Read Phil's stuff, but build whatever you want. You want chickens, you want, I don't know, whatever, it doesn't matter. Thank you. Yeah.
Hi, Brad Banco, Cleveland, Ohio. 2 questions. First one's a quick one for Dr. Pinckney. In your business, how do you manage the DPC benefit for your employees or your company members and employees? Do you deal with the HSA angles, the tax, the pre-tax angles, or do you just make it a direct benefit? I mean,
do you mean the people that are employed by his business, or
yes,
the employers he negotiates with?
No, the people.
His employees.
Exactly.
Okay.
We make it a taxable benefit,
Okay.
and I actually pay for it. So we don't charge any employees for the DPC piece.
And then the other part of your health insurance for your business is ACA compatible.
Right.
So you don't have
It
to worry
actually
about
is it's a no network freedom plan, so our employees can go anywhere in the country, and there's no network and there's no back billing. So the TPA and the insurance carrier we have reinsurance for anything over our stop loss, but I've got a 4-month-old, so we just had a baby, and I had an astronomical bill from the hospital, almost $40,000. And I'm like, this is what I do for a living. I know these charges are marked up ridiculously high, but I had to talk to the insurance carrier to make sure that they weren't back billing because they weren't honoring the negotiated rate, 125% of Medicare. So it was a mess, but it's a great plan.
Okay. And my second question is sort of a general question about problems with this model across the scope of general practice. So are there some common problems? I think I heard somebody allude to immunizations for children. If you could just talk a little bit about some of those common problems.
So,
thank you.
Dr. Jen, will you lead us off on the dark side of DPC?
Sure. Am I on? Yeah. Okay, so problems. One problem I would say, and I guess I would make this maybe my pearl, kind of goes along with what Julie was saying earlier about, are you likable? The other problem is that when you offer people this model, there's this really quickly perceived two-way intimacy, which we perceive as one way, right? Like, you're out there telling me all your secrets, but don't know anything about me. And so it gets deep with patients really quickly. And I think that can be exhausting sometimes. So that comes down to making some good barriers. And I would say if there's a downside to it for me, that's what it is sometimes I'm just emotionally exhausted by people because they bring so much and they expect so much back from you. All those barriers of people that, you had to help pay for before, like receptionists and MAs, number 1 and number 2 and number 3, and all those people that were between you and the patient before are gone. So there's a lot of access, which is it's a double-edged sword for sure. I think probably, Jessica, you'll speak about immunization. We are working on a solution to immunization from a practical standpoint. That's probably our biggest barrier. Occasionally we run into issue with referral for specialty, but there are a lot of really good solutions for that. But immunization is a tough thing for sure.
I'm not really sure what the immunization question, if that's more of the expense, the storage, the hassle. There's many layers to that, but I just do it. Nobody told me it was going to be hard or you couldn't do it, so I just figured it out and I do it. I see about 70% peds in my practice. Half of them are probably on Medicaid HMOs, and it just somehow has been working. So New York State, we have a vaccine for children program where we have to order a separate supply from the state. We get that for free for kids who are uninsured or on Medicaid. So I have to keep that supply in the fridge and then follow all their regulations and get a site visit. So there's hassle. They have all sorts of rules, and I don't like rules, but I do it. And I hired a nurse because then I can hand most of that headache off to her. And then I order private vaccines for the privately insured kiddos, and I do bill the patient the cost of the vaccine plus a small administration fee. They pay me up front, and then I give them a super bill with the codes to submit to their insurance, and that seems to be working 98% of the time. So you feel free to contact me with your specific questions, but you can usually figure it out. Some people send people to the health department. I felt in my practice I charge more for kids. I do everything backwards, if you haven't gotten that already. So I felt it was really important to capture them while they're at my office. They don't want to go to the health department. They're paying me money to have access to me. So I felt that was important. I also get a lot of not really wanting to vaccinate patients, so I feel it's important if I get them to commit, then I can do it then and I have the vaccine. So again, they're not going to follow up with the health department, but it works, and I'm getting people vaccinated and getting paid without dealing, I'm not losing money on the proposition.
So other comments on what you see as some challenges or difficulties of DPC? Or maybe, there's often questions that run on the theme of, I didn't do this in system employed private practice, but do you do this in DPC? Does anyone want to comment on that kind of a theme?
I think, going into DPC, for me, was, again, it's about relationships. And if you want to have a different level of relationship with your patients, you have to, that's what brings the value for me of my practice. And so they get a little bit more in your space, and you're more out there, and you're more accessible. So you have to be okay with that to a certain degree. So you have to have some boundaries that kind of put some parameters on it. But for me, it's kind of, it's like when I was in the fee for service, it's like, patients or friends would call and ask me, advice on certain things, and I would be always, call me anytime. I'm like, well, why can't I do that with my patients? And so that's how I am with my new DPC practice. But you have to have boundaries, and so far from my practice, everybody's been pretty good. So very respectful of my time.
One thought I have is I guess two pearls. One is I had a lawyer who was a very nice lawyer who owned his own business, and he said, Dr. Julie, the one rotten apple spoils the whole bunch. I find it incredibly therapeutic to scroll through my patient list sometimes and see, screen after screen after screen after screen on my rough days. There are, in a practice of 600, I probably have 18 patients that if I let them go, my practice would be like Dr. Davis's, just 99.9% joy. So with any business, I think you need to be mindful of the customers that are not the right fit for you, is maybe a tactful way of saying it. The other thing I'll say, and Dr. Jen alluded to this a little bit, but be mindful. We have big hearts, but you don't have to take care of everyone. And I would contend that in trying to do so, you're going to destroy your capacity to take care of most everyone. So no business goes out and solicits to their worst customer, right? So when you are transitioning, within the realm of who you want to take care of, who has helped fill your bucket, who has helped you feel like a doctor, those are the people that are going to come or want to come with you. The patients, I can't remember whose presentation, Dr. Doug's, the patients that before you go in the room, you're like, can do it, I can do it. Oh. You know, and you're not sure if you're going to get yelled. Those patients probably, they will want to follow you, but that's not what you're trying to build, so be mindful of that. The other dark side for me is billing is not complicated, but I should have instituted very strict, very firm rules for me about patient termination for lack of payment. We have an instant quick fix society, and people are not always willing to invest in you, but they want you to invest in them. So clarify your business model. Mine is very simple. You pay me every month, and I'm your doctor. Some people can't handle that. They won't pay me every month. So being really, really firm with not getting behind on collections, because then you have 4 months unpaid and they call in, and what do you say? I'm not gonna see you till you pay. I want a refill on my metformin from your pharmacy, it's cheap. Well, you're $400 behind. So it creates some business challenges if you're not pretty fierce about your own boundaries. I have a narcotic contract with my patients. It's actually written for me, because I get too tender-hearted. And so when we've mutually agreed to that, I can say, these are actually rules for me. These are the terms of my willingness to prescribe this. So I think we're here. Yeah.
First, I want to say thank you to all speakers giving for your sharing your very valuable experience and also opportunity for great network. I am a doshi and full-time internist at present and thinking to transition for DPC. I have two things in my mind. I'm asking again, we repeated so many things, but still few tips, like a top tips or what in your mind for marketing, and second thing, 2 tips, how to make more bond or trust with the patient. And second thing, I'm also thinking, I see also in my community and everywhere some like a dentist, chiropractor, they have home and office in the same place. So I am thinking that model to cut down the overhead and cut down the time. And second thing, can we have something model like urgent care rather than family practice? So if anyone has a thoughts or some ideas, I would appreciate.
Right. Okay, so lots of questions there, but all very good. So ideas about marketing and building trust with your patients. Has anyone seen basically cash-based urgent care? Let's save that one to the end. And then working out of the home. I'll comment on that. There is a physician named Sharon McCoy George, who I'm sure I don't like to speak on behalf of her, but I've spoken with her before. She actually did work out of her home in California. Her direct primary care practice was largely her extended neighborhood. She used to mentor, anyway, I can see if I can give you her information or anyone else that's interested. She is on Facebook, but she's kind of the go-to for that discussion. I don't think any of you guys work out of your home. So, do you work out of your home? So, Dr. Campy over there works out of his home. So you connect, okay? Thank you, yeah. And then, so marketing and building trust with your patients. How about Dr. Kissy, since that's what you're doing all the time for the last 6 months?
Marketing, I really haven't done a lot of targeted marketing. I felt like I know I've talked to a lot of people, and most of the doctors up here will tell you that print and TV and all of that type of thing that are very expensive tend to not work very well. So I didn't want to go that route and spend a bunch of money that wasn't going to work. So I do a lot of Facebook posting. I think that has probably been the best thing for me, and and a lot of my patients are also young families, and so that was kind of the perfect target for me. Facebook marketing, I did do some town hall. I did one town hall, and I also did like a girls' night out networking event. So any type of thing that sort of comes in like that, that's sort of part of the community, I think that's a really good way to get patients. Church groups, mom groups, those types of things where you can just go. Usually it's like, you set up your table or whatever, and then you just talk to everyone that comes by. And that, I think, was probably one of the better things that I did to do more marketing.
if you learn about these physicians later, everyone has a pretty straightforward web presence. I think Dr. Kissy and Dr. James won on SEO on my iPhone this morning in terms of popping up first, but a very functional web presence, a functional Facebook page. It's very clear on all of their sites how to sign up, where to sign up, sort of personal writing about their vision. So from my perspective, all of these people have done an excellent job with the clarity of their own, there's a pun, she's Clarity Direct Care, the clarity of their own website. So who else wants to talk about marketing or trust? Yeah.
As far as marketing, I think a lot of people have said this weekend, word of mouth is always your best marketing tool. I did learn after being in practice about 6 months the power of Facebook. There is something to keep in mind, and maybe this is my small town perspective about print advertising. Remember your local newspaper, local magazine, there's an editor, there's a publisher, there are employees, and so I may not get any patients from that ad that I put in, but I'm helping their business. And in return, I get members, if you will, from that. So think about, again, how you invest and spend money in the community, because that's what we're asking them to do with us. As far as building trust, the best thing I think I do is I walk in the room, I don't have a laptop, I have a pen, I sit down and I keep my mouth shut and listen, and they're not used to that, right? And that's the best way to start.
I had one patient that came in the other day with a list of 2 pages of things that he had written down from over the years. No doctor had ever listened to that. I had an hour and a half that day, and so I listened to everything he had to say on both pages, and then he stopped and looked at me and he was like, I think I'm going to cancel my WebMD account. That was the best thing he could have said.
If I could, I want to address the issue of trust with the patient. As much as we are beat up by the system, patients are beat up by the system too. And so, our practice is over half uninsured completely, and those patients had nowhere to go. So they come to our beautiful practice and they sit on our leather couch, and we treat them like gold, just like everybody else that comes through the door. And when I first hand them my card and I say, this is how you get to me, or the first time I answer the phone and they say, I didn't expect it to be you, I'll call back. And they start to relax a little bit around you, and they start to realize that you're there for them and that you care about them. Now I realize I am speaking out both sides of my mouth, because I just said that's one of the hardest things too. It's this intimacy thing. And so from both sides of that, you're figuring it out. You're figuring out, how far does this relationship really go? But I think in terms of bonding with them and building trust, you're really saying, look, I trust you to contact me when you need me and not when you don't really. And then you can trust that I'm going to be there when that occurs. So I think that's been the biggest thing to build trust in our practice.
Quickly, I do a meet and greet for everybody that comes into the practice. So that's a half an hour, no medical issues. Just let's sit and talk, see if it's a good fit, get a gut feeling for each other. I think that goes a long way. Some people, it's not, and they won't come back. But to just sit down and get a feel for what it's like to be in the office, to talk to me, to run some things by me, that works. And for marketing, I am a fan. Again, I have a more niche practice, but if you want to see Medicare patients, where do they hang out? What's their community? How do you access that? I want to see kids. I talk to the home birth midwives, the lactation people, and that word of mouth spreads very quickly in the community. So it's come up a couple times, but accessing those kind of key people or key groups in the community will spread things, and you don't have to take everybody that comes along. You can tailor your practice a little bit. You're going to be small if you're going to be small and not go for the big franchise version. Who do you want to see every day? Who are your favorite people? You're going to see them all the time. So fill your practice with your favorite people.
Dr. James, you have a different marketing experience related to the Super Bowl I understand. Do you want to comment on what that did to you and your practice?
So this is a wonderful marketing pearls. I'd like to add that when you're first starting out, do things that don't cost any money. We spent a ton of money. I spent $25,000 on a sponsorship with SMU. We had a commercial going in the Moody Coliseum. We had a booth. We were there meeting, greeting fans. It's 2 miles from our office, and we had 0 conversions from that investment. And referencing the Super Bowl, I called Vistaprint. This is about 4 or 5 years ago. And I noticed that their commercials ran constantly on Saturdays during football season. And I gave them a call, and I tried to put my name in the hat for one of their small business commercials. And I actually got all the way up to the final 5 or 6 businesses, and they ended up doing a Skype interview with me. And I hated the way the interview was going. It was very bland. The executive producers were there, and they're actually out of Europe, and some of their leadership team had flown over. So I stopped the interview, and I took them on a tour of our office with the computer with my laptop. I treated them as if they were a new potential client, and they were blown away by the DPC model. They kept asking me questions about DPC, and eventually they chose me for their small business spot. Ran for 2 years. It was kind of the turning point for our practice. 18.9 million people saw it on Monday Night Football. 18,000 unique visitors within 30 seconds to our website. And lots of emails to my personal email account because it was on the business card. So, and again, that didn't cost me a dime, and it was worth tens of millions of dollars in national advertising. So do things, be creative, reach out to your local newspapers. They would love to write a story on this model, even just contributing to different healthcare topics to local radio stations. Do things that don't cost any money.
Yeah, thank you. Yes, you've been waiting a long time. Thank you.
Kate from West Virginia. I had 2 questions. First, do you typically charge an initial enrollment fee in addition to the monthly membership fee when people first sign up? And the second question is, sometimes we have people call the office who are not current members and they don't plan to be members, at least at that time, but they'd like to set up an initial visit. Do you typically see those people? And if so, what is your procedure for one-time non-member visits?
So is that people who are curious but not sure they want to sign up?
Potentially, but sometimes they clearly express that they just, maybe their current physician is out of town and they just would like to be seen
Okay,
for
so
one time.
the same day visit kind of idea.
Mm-hmm.
So how many of you with a raise of hands charge an enrollment or sign up fee? All the ladies, interesting. Do an analysis on that. And then your second question was, so how many people will do a one-time visit? Okay. As a percentage of your membership, what do you charge for the one-time visit?
So the acute visit has to be more than your highest price point, or you disincentivize people to join the membership piece.
Yes. Yeah. We did acute visits for about a year and a half as a way to spread the word. It didn't pay. And that's the wrong way to say it. I don't mean financially. I mean the amount of incredible effort. My thought was talk to anyone who wants to hear, and if someone has a same-day need, you have to think about what you're trying to build. And in my opinion, someone calling at 10 a.m. who wants to see the doctor that day for an issue that day and has no intention of making any long-term investment in their health care, because my price point's lower than the federal qualified health center around the corner, which is a pricing problem, is not someone who's interested in investing in your vision. So it solves a very transient problem, which is, hey, what's the point of me sitting here seeing nobody when I'm growing? Might as well have that revenue. But for, we'll say an average, for $77, is it better for you to go to the gym or better for you to provide one-off care for someone who's really looking for an urgent care quick fix, right? So we did that in the beginning, and then I realized I think it contributed to substantial personal exhaustion. Because I was really investing in people who had no intention of investing in this model. So one of the things we do now is we do not ever do a new patient same-day visit, which I think you need to do in the beginning, but need to be really mindful about in the beginning. You have to hustle and work hard in the beginning, but after a while we figured out that same-day new patient visit is usually a request for a controlled substance or someone who just doesn't necessarily have the administrative capability to commit to a long-term relationship. It's like calling up Gold's Gym and being like, yo, can I just come in today and run on the treadmill, but I don't want to play with the rest of the business model, right? It's just, so that's my thought on that. But yeah, so we have 6 minutes and 26 seconds. What I would like to do, thank you, is have each of the panelists, you have about 30 seconds, I'll time you and beep you out. No, give some closing thoughts to these physicians. So we'll start with Dr. Jessica, because we'll go the other way. What are your closing thoughts or pearls for everybody?
All right, my pearl would be, I guess, define your version of success for your ideal life. We talk about building our ideal practice, so your practice has to be part of your life and not kill yourself the other way around. That's why you're getting out of the system. Don't just put yourself on another treadmill in your own business. Have that clear vision for your life and your practice, and then stick to it. Stick to your principles, stick to your boundaries, and build something that's sustainable for you and your patients that you want to do for the rest of your career, your practice, and your life. I think that's enough.
Closing thoughts. I look at DPC truly as the future of healthcare in America. It offers better patient care, better quality of life for physicians, and it tremendously will decrease the spend of healthcare in our economy. I call that a triple win. Everybody up here and all the physicians that have spoke this weekend have bet their careers that DPC is the future, and we encourage all of you to join the movement, start your practice, take that leap of faith. It will pay off.
My closing thought is that I think this is the time as you work on this transition to start saying no. I think most of us probably are at the point we're at because we said, yes, I'll see more. Yes, I will be on this committee. Yes, I will try harder. Yes. And this is the point to say no. And while that sounds counterintuitive because you're trying to build a practice and build a business, don't be so desperate that you let everyone in. Don't be so desperate that you start to do things that you didn't think that you would do, like partner with someone else who promises to send you revenue when you don't have the same philosophy. Say no. Take a break from saying yes to everything. Figure out what your vision is and say no. And I'm giving this advice right back to myself right now as well.
So I'm going to paraphrase Steve Jobs, who said, follow your heart and your intuition. They've always known what you truly want to become. And I would just add to that, also use your head, not just your heart and your intuition. Use your head and use your resources. This meeting, Julie, Lee, they're incredible resources that have helped all of us. But I think the most important thing is think about why we all went into medicine. And is the path that we've been on or on now, is it really fulfilling that? Because I think for many of us, our heart and our intuition told us or telling you, you want to become something else. That's why you went into medicine.
Yeah, so I'm going to give people a little bit of a charge here. I'm a much smaller person than Vance Lassie, but I think this is my inner Vance coming out as well. We're family doctors who we're largely family doctors in this room, who trained doing inpatient care, who trained to deliver babies. We want to care for our patients, and we want to love them and be there for them. And some of the most high acuity times of their just stress in life are those hospital visits and those deliveries. And I would charge some of you, you can do that with DPC. And we're doing it with our practice. And yeah, I would give you a charge that I think you should take that back and talk to me if that's something that you're interested in doing.
Take it back. My pearl would be, when I was at the summit a year ago, is the first time in my doctoring life where I've been in a group of other colleagues who want everyone else to do well and are willing to give their time to help you make this right. Find a mentor. Talk to people. I would not be here without this lady. She's awesome.
Even though I scrambled your brain.
Yeah. Anyway, just talk to people.
I think what I would say is don't be afraid. Don't be afraid to do this. I am not a business person. I know nothing about business, but I am running my own practice I never imagined I would do. And it's because of these people, all of these people that have, answered millions of questions that I've had and just, gave me the power and the realization that I can do this. Because if I can go to medical school and do an MCAT, I can run a business. It's not that hard. So don't be afraid to do it. Jump in there and do it.
So I would be remiss to not thank my mentor, even though I've sort of grown some of my own wings, who's Dr. Josh Umbar, and all of the people in this room who continue to give me great light and energy and mentor me in so many ways. So I'm going to be a little cheesy, but my closing pearl is that we all need to start telling our story and painting our own picture. And the only person who can paint your picture is you. Your authentic contribution to humanity is needed, and I would say potentially very few other times in American history, more so than now. So doing anything other than what you have been authentically called to do is a waste of the amazing contribution you have to make. So stop being afraid. Put on your big girl panties and your Bill Murray shirt. I do wear Wonder Woman underwear. That's oversharing, but I do. Go get some. It helps. And be the physician you set out to be, because we need that. So Lee, we're done. 26 seconds over.